Hi. So today we'll talk about seizure medications when they do not control your seizures. So do you have epilepsy that all the seizure medications you're taking and seizures are still happening despite you being on multiple seizure medications? Well, today this video is for you because we will discuss all the new treatments for epilepsy and the treatment strategies when the anti-seizure medications do not work with your epilepsy and how to treat that effectively. So first of all, the treatment for the name of this condition is drug-resistant epilepsy. So drug-resistant epilepsy is a condition when the seizures and epilepsy do not improve with medications. For us to first diagnose that somebody has a drug-resistant epilepsy, and when seizures fail to control their seizures, their medications fail to control their seizures, then we have to say that there is a definition. So the definition for drug-resistant epilepsy is that the failure of to get sustained seizure remissions means that you have no seizures. The failure to do that, despite being on two medications, either alone or combined, that are appropriate, means that the right medicine for the right seizure type and appropriately chosen and appropriately given, it means that the medicine was lasting for a long enough time, and that with combination or alone they failed to sustain seizure freedom. So if somebody is having epilepsy, they took their medications and seizures are still happening, then we can diagnose drug-resistant epilepsy, or in general, resistant epilepsy or refractory epilepsy. So this is a real problem because about a third of the patients, so that's not a small number, about a third of patients will have drug-resistant epilepsy at some point during their epilepsy condition. So what happens is that medications, when they're given to patients, luckily they will stop about 50 to 70% of seizures. However, at some point when the seizure medications do not stop the seizures, then this is drug resistant, and it happens in about 25 to 30% of the time, which is a lot. So about a third of patients that we treat with epilepsy, they have end up drug-resistant epilepsy, and the seizures continue to happen despite being on all the medications. And their neurologist will keep switching them from one medicine to another, from one drug treatment to another, and nothing seems to work and nothing seems to help their seizures. Well, today let's discuss what can we do, because there are a lot of things that we can do to help your seizures and even stop them completely. So today I will give you all the treatment options and what are the testing, what are the treatment, and I will show you all the treatments that we go and the devices and everything. So brace yourself for lots of education and lots of information about epilepsy coming from directly from the epilepsy neurologist. I'm Dr. Omar Danoun. So the first thing we consider when we are diagnosing epilepsy is the fact that we have epilepsy and we have seizure that is drug resistant. So the first thing we have to do is testing. So when seizures are not controlled, the first step you need to go is discuss with your neurologist or go to an epilepsy specialized center. Epilepsy specialized center is a center where the epilepsy specialized doctors have, and they test the patients and have much deeper experience in epilepsy and seizures. So you really want to see the epilepsy center, and we do a video EEG monitoring. So video EEG monitoring is a special test that we do to diagnose the seizures and epilepsy. So we bring the patients in and then hook them to an EEG in their head and do monitoring for them. And that monitoring usually lasts for a long time, preferably anywhere between 1 to 5 days or even longer. And the goal of this monitoring is first to diagnose the presence of epilepsy, and second, to diagnose where the seizures are coming from and if we can do something to tackle them and treat them. So the first thing is that diagnose whether somebody has epilepsy or not. To be surprised, about a third of patients that were labeled as drug-resistant epilepsy and then having seizures that are not stopping with all the medication and they keep fainting and keep having seizures, about a third of them, they do not even have epilepsy. And that's like a surprise. Like, I've been labeled as epileptic all my life, and now I do not have epilepsy. Well, here's what happens. You might be having what we call psychogenic non-epileptic seizures, which is a seizure disorder and shaking, but the origin is not excess electricity in the brain. It's rather brain function changes and psychological origin. And in this situation, the treatment will not be more anti-seizure medication. It will be behavioral modification and psychotherapy and treatment of any overlying conditions. So, but it is important that to differentiate between epilepsy and non-epileptic seizures. Okay, so if you do have epilepsy, and then maybe like you have other conditions such as fainting spells, arrhythmias of the heart, there are multiple things that can mimic and look like seizures, but actually they are not seizures. They are something different. So the first step is to diagnose if you have epilepsy or not. And then the second step, if you do have epilepsy, the question is that what type of epilepsy you have. We have two major types of epilepsy. The first one is focal epilepsy. So focal epilepsy is that when seizures are happening from one single spot in the brain, and seizures start there and spread throughout the brain, and this is called focal epilepsy. And this type of epilepsy, they call focal seizures, simple partial, complex partial seizures, or focal seizures now we call them. And this type of seizures, all medication work for them. And the second type of epilepsy is called generalized epilepsy. So generalized epilepsy is when seizures and epilepsy comes from all over the brain. And this is a special type of epilepsy and seizures. So it is important to differentiate what type of epilepsy and seizures you're having and the patient is having to know what exactly we need to do for treatment. All right, so we diagnosed epilepsy and we diagnosed that somebody has epilepsy and maybe focal seizures or generalized epilepsy. And then the second question we ask ourselves is where the seizures are coming from. So if we know where the seizures are coming from, we can treat them with other treatment modalities that we will discuss today. So here's the thing. The first thing is that what are the chances that medications will control your seizures? So it is surprising statistics that I'm about to tell you. So the first medication is the best medicine for you. The first medication likely will stop the seizures in about 50 to 70% of the time. And then we're left with 30% of people do not get a response with those medications. And then if the first medication fails to control your seizures, we go to the second medication. If the second medication fails, the chances of that controlling your seizure drop significantly to about only 15%, 10 to 15%. And that is really drastic change. And that is because the epilepsy has proven to be a little bit more stubborn and difficult to control with medications. If two medications do not get controlled with seizures, then at that time we are dealing with drug-resistant epilepsy, and the chances of any more medications controlling the seizures completely and stopping the seizures drop significantly to about 1 to 5%. Well, that's a surprising number, 1 to 5% only. So that means if you fail to control the seizures with two medications, any other medication you add with your neurologist will not likely to control your seizures. Actually, just 1% or to 5% will improve. So stop wasting time with trying more and more medications. It's time to move to the next step of treatment. All right. So with this statistics in mind, only 1 to 5% will improve with any other medication. So definitely we take medications, but sometimes they do not control the seizures 100%. Maybe things will be worse without medication. So we'll continue to take medication, but we seek other treatment. All right, so now we go to the next step, and which is the potential for some surgical treatment. So how can we do that? So the first step, as we did a video EEG monitoring. We localize where the seizures are coming from in the brain, and we know where the spot is. And if we can isolate the seizures to one single spot in the brain, that is a great scenario. And we can tackle that surgically and take it out and cure the seizures completely stop. So this is what happens. If you have a surgically resectable area of the brain, especially the mesial temporal sclerosis or that area, there's a scar that we can take out surgically, the chances of curing your seizures significantly improves from 1 to 5% into 50 to 80% of the time, which is a huge increase in the chances of controlling the seizures. And this is really a good chance that we can make a difference. So surgical treatment really is important. And seizures are not benign. And there is a surprising statistics. It's like 1 in 1,000 people with epilepsy, they die every year because of SUDEP, or sudden unexpected death in epilepsy patients. So seizures are not benign. They can cause injury. They can cause even death. So it is important to control the seizures better because you want to prevent any morbidities and mortalities from the seizure. All right, what other tests? So we do the EEG, we localize where the seizures are coming from, and then we do imaging studies. So imaging studies such as a brain MRI, so magnetic resonance image, brain MRI, it's a great detailed picture of the brain that we do to localize what areas of the brain are responsible for having the seizure, and usually comes back positive in about 30 to 50% of the time. And we have a specific MRIs for epilepsy, we call epilepsy protocol, that looks in details to the epilepsy areas of the brain, especially the temporal lobe. And it is best if it's read by an experienced neuroradiologist that can look at the brain MRI and diagnose it and give us the information much better. So MRI of the brain, and we can do other testing such as PET scan. So a PET scan is a PET, is a nuclear medicine scan. We give a dye that goes to the brain with sugar, and then the areas of the brain that having epilepsy, they have a different signal, so we can diagnose where the seizures are coming from in the brain. And we do other testing such as MEG or other modalities, functional MRI. So the reason why we do all the testing is to diagnose where in the brain the seizures are coming from if we can take them out surgically. So the second step, if we isolate the areas to one area of the brain, then what can we do to treat that? So, well, the treatment can be in resection. So if we have, like, let's say, like this is the brain, here is the brain, and we have seizures coming from this area called the temporal lobe. That's where most of the seizures happen, and most of the seizures are located. So in the temporal lobe, that's where the seizures are likely to happen. So if in the temporal lobe, so let's say like this is the left side of the temporal lobe, so this is the temporal lobe where the seizures are coming from, we do mapping of the language and other functions of the brain so that we do not take an area of the brain that is functioning and cause damage to the person because of that. So we map, so usually here is the area called Wernicke area. That's area responsible for language and talking. This area, Broca area, that you will talk through. Here are the areas of the movements and sensation, move your arm and all of that. So there are different areas of the brain that have different functions. So if we are successful into locating where the seizures are coming from, there is a scar, the cells are not forming right, there is any trauma or anything that caused that scar or abnormal cell function, then we can prove that the seizures are coming from, and then we might do another surgery to implant and study the seizures from inside the brain. And after that, if we can localize the areas of the brain that are causing the seizures, and it is safe to resect them, to take them out, then taking those out can be successful and can be curative and can improve the seizures significantly and stop the seizures in patients who never had any improvement in their seizures before. So it is important to think about surgical treatments for epilepsy because it can really change lives and even saves lives because of that. All right, so this is the first treatment, which is resective surgery, the most successful and the thing that we desire the most. If we have one spot in the brain not functioning very well, we can take it out and cure the seizures. All right, if the seizures are not improving and we have an area of the brain or multiple areas that we cannot take out surgically, what can we do? We do not stop here. We can move on forward with devices and implantation. So other devices that we can implant is called vagus nerve stimulation, or VNS. So let me show you what is the VNS device looks like. So the VNS device is a device that we implant in the brain. So this is the VNS device. So it's really a small device that we can put, like it's in the hand. So this one device will go under the clavicle in the chest. And this is the wire. So this is the wire that goes in on the vagus nerve in the neck. So this wire will wrap around the vagus nerve and then will tunnel under the skin and then hooked up to the device. So it is important to consider this device for the treatment of epilepsy. This device is good. It works for all types of epilepsy and seizures, and it is implanted under the skin, so it will not show up anywhere. Like it's just under the skin, small amount right here on the left side. So no one will see it and you will not feel it. That's going on. So what does the vagus nerve do and the vagus nerve stimulation? So vagus nerve stimulation helps to stop the seizures, and it works at about 5 to 10% and even 15% to stop the seizures completely. And put in mind that the chances of stopping seizures is only 1 to 5%. So this device provides much better chances. And this device is considered palliative, means that it helps to calm down the seizures. And the chances of this device helping you is more than 50%, will have more than 50% reduction in their seizures, which means that it will drop the seizures significantly. And we noticed that where people have this device implanted, they will have less intense seizures when they happen. So they will be shorter and less intense. And the post-ictal state, like the time after the seizure, instead of being confused and tired for a long time and sleepy, it will be much shorter. So shorter seizures, less intense, and hopefully less injuries. And this device will come up with an auto built-in heart detection. So it will detect the heart rate when there is a seizure. It will give extra discharges to stop the seizures. And there is a magnet that you can put in your hand or like swipe it. That will give extra discharges in case a seizure happens. So this device is effective, helps with seizures. So it is important to consider if you have epilepsy that is not controlled. So what are the complications and side effects of this device? Well, it can happen that it has complications and side effects. First of all, a surgery complication like infection, bleeding, or any changes like nerve damage. Those are very rare, happens like 1% of the time. And the second complication, because it's wrapped around the vagus nerve, this is the nerve that controls the speech and the vocal cords. It can cause hoarseness of voice. So if you're a singer, then this device might affect you. And I have like patients who are singers and they are using this vagus nerve stimulator. They will put the magnet on the device and that will shut off the device for some time until you take the magnet out. So and during the concert, you put in the magnet and then it will be fine. So we can decrease the programming of the device and it works well. So this device is considered one of the good devices for epilepsy, and this is the oldest one. All right, so this is the vagus nerve stimulation. What can we do for other devices? So other devices will be the deep brain stimulation. So this is device number 2. So deep brain stimulation is a device that we implant into the brain, and this device is implanted inside the brain in a strategic area called the thalamus. So here is how this device looks like, and what we can do for this. So this is the wires for the device. So it will come up with 2 small wires. So this wire is very, very small, tiny seeds like the less than pencil head. And so this is the brain. This device will go like deep inside the brain, into deep of the brain. It's called the thalamus. So this is the thalamus. And then the thalamus is where the device is located and stimulates. So why we are stimulating the thalamus? So it is important to know that how the electricity flows into the brain. So usually electricity comes from the connections. There is a circuit called PAPE circuit from the temporal lobe, goes to the thalamus and goes to the frontal lobe and comes back to that. So this is a strategic area. So it's kind of, you think about it as like the hub for the metro station. And the metro station is like the seizures come, and that is a strategic area where we can stimulate. So discharges will come all the way. It's kind of like the downtown metro station comes from all over the city to that downtown metro station, and from there we'll go to other areas of the city. So if we stimulate that area strategically, then we can cure the seizures and help them so much and disturb them on their way to creating more damage and more seizures. All right. So this is the device. It's a very small, kind of like, it's a little bit bigger than the vagus nerve stimulator. It's a device that is like a little bit bigger. It goes into the heart, into the chest. So we implant it here in the chest, and it will be stimulating that area of the brain, and it will go directly into the brain. So this device is good. It helps a little bit better than the vagus nerve stimulator. It goes from about 5 to 15 to even 20% with time. It gets better with time. And this device, the complications of that device is usually the same as any device implanted in the brain. Can have a little bit of infection, some issues with bleeding, which are rare. And neurosurgeons who does that, usually they're experienced, and so that complication rates are a little bit lower. And the other thing is that because it's in the area of emotions and connections in the brain, it can cause depression as a side effect, and we usually be aware of that. So if you have depression, that might get worse with this device. So that's why we try to kind of come up with a better stimulation parameters and decreased the stimulation intensity, and that can help a lot with depression. And so this device can be considered, and it works for focal epilepsy and generalized epilepsy, mostly for focal epilepsy, the temporal and frontal lobes. And it is being studied now for generalized epilepsy with a different target in the brain. All right, so those are the 2 devices for epilepsy, and we have another device. So if we know where the seizures are coming from in the brain, we can stimulate that area specifically, especially if it's an area of function. So, for example, if we have multiple areas of the brain, 2 areas where the seizures are coming from, we cannot take them out surgically, or we have the seizures coming from an area where you have thinking or you have talking or sensation, then we cannot take it out. So then we can implant a device to help with that. So this is called responsive neurostimulation, or RNS. So let me show you this device. So this is the responsive neurostimulation device, the RNS. So the responsive neurostimulation device is a device that we implant in the skull. So this device will go into on the skull, inside the skull, and we carve it there. And in that area, we look where the seizures are coming from the brain. If it's on the surface of the brain, let's say like this area is responsible for movements of the hand, then we can put a strip on that area like this, and then connect that strip to the device, and then that will stop the seizures in that area. Or if it's in deep of the brain, then we can implant this device, go inside the brain, and then we can go directly to that area where the seizures are coming from. And this device is a very smart device. Actually, it has a computer inside it. It will read your brain waves all the time, and then when it sees the seizure, it will deliver discharges to stop the seizures as it's going. And it has a computer that analyzes your brain waves all the time and deliver discharges for those seizures to stop them right away. And it will store the information for us to review later. And we train the device to recognize the seizures of every single patient individually. So it's kind of like more of individual treatment. And it will tell us sometimes you have seizures that you do not remember or you're not aware of. So it gives us a good information and feedback about how your seizures are going in the brain. All right, so those are the devices, the 3 devices and resective surgery. What is new and what are the treatments that we can do more? So the new and hot topic in epilepsy surgery is laser ablation. So can laser treat epilepsy? The answer is yes. So it is interesting that now we have treatments with laser ablation that we can put in a small laser wire into the brain and ablate an area. So this is how it looks like. So this is the surgery for the laser ablation. So in laser ablation, we put in this wire goes into the brain, and then it will create heat, and that is in the brain MRI. We do MRI directly when we are doing the surgery. So we will do that during the surgery, and we look at the heat map. And once the heat is high enough to just damage that small area, then we can treat it. And then we pull back, and continue to ablate. And this is how it looks after the surgery. So laser ablation is a hot topic. It helps a lot with seizures that are really focal, localized to one area. And me and my team and other epilepsy neurologists and neurosurgeons, we are studying this in research and actively looking at that for it to be the next treatment for epilepsy and seizures. And actually, this is one of the new modalities that is minimally invasive, and the patient will just go back home the second day, or like its recovery is very, very quick. Not everyone will benefit from laser ablation. Usually it's reserved for the clear target mesial temporal sclerosis, or MTS, in the temporal lobe epilepsy. When there is a clear scar in the hippocampus, it is hardened and sclerosed, so we can take it out instead of taking out surgically and go open the brain and do the surgery. We can just laser ablate it, and that will help the seizures a lot. So it is very, very good treatment for seizures and epilepsy. And it is definitely a hot topic that we're studying. And the benefit of that, it has less memory issues and complications than other conventional surgical treatment. So those are so many different modalities for seizures and epilepsy. So you might have a question, is surgery available for me, and is it the right choice for me? So well, it is important to understand that surgery, it can be a treatment for drug-resistant epilepsy. And for that, you need to see the epilepsy center that is experienced and know how to do those surgeries. So definitely ask your neurologist if you can be referred to an epilepsy specialized center to look for surgical options, especially if you failed 2 medications to control your seizures. So that's important to ask. And then every country in the world, usually they have an epilepsy specialist or an epilepsy center. In the United States, we have so many epilepsy centers. So look for like a level 4 epilepsy surgery center that can do surgeries, and definitely you will find lots of more answers in that area than maybe if you have that not like epilepsy specialist neurologist. Now we have specialization in epilepsy and epileptologists, and that's a very important to understand that we have specialization now, and every seizure has like a treatment that's specific for it. So if you have treatment, epilepsy that is resistant to treatment of the seizures, what can we do? Like even if the surgery is not an option for me, we have diet treatment. So the ketogenic diet is an important treatment that we can use to treat seizures when do not respond. So the chances of seizures being controlled with medications is about 1 to 5%. So if we have seizures that are not controlled, we can do diet therapy. And actually the diet is very effective. It can reach up to 40%. So there's a huge improvement in chances of controlling the seizures with diet therapy. So ketogenic diet was there like since ever. Like Aristo usually used to treat his epilepsy patients with fasting because they noted fasting improves. And then in the early 1900s, Mayo Clinic pioneered ketogenic diet. That's where I trained for epilepsy. And they started using ketogenic diet for epilepsy, and recently now it is a trend, and we had so many studies proving that ketogenic diet helps a lot for epilepsy treatment. So it's important that ketogenic diet is given to you through an experienced neurologist and dietitian, that is nutritionist, help that knows ketogenic diet very well, because ketogenic diet is not for everyone. Some people will tolerate ketogenic diet well, some people do not. Some people have even genetic disorders that forbids them from doing ketogenic diet. So definitely you need some testing before that. Make sure that you don't have any problems in the mitochondria and the liver and the enzymes that makes ketogenic diet harmful for you. So it is important. So if you cleared, then you do ketogenic diet. It helps so much with epilepsy and seizures, and it's a very important thing to do. So if you have a ketogenic diet, usually it works very well for children because we feed children, we give them what to eat, most of them. Sometimes they're rebellious and don't want to listen to us, but we feed the children and we plan their food. So it is, it's easier to plan the meals and give the child the food. In adults, it's a little bit more difficult to stick a rigid ketogenic diet. So that's why we have alternative to the ketogenic diet that gives you the treatment benefits with less stringent weighing and eating. So that when we do ketogenic diet, we increase the fat and the protein and we decrease the carbohydrate a lot. Then that will put the brain and the body into starvation mode, will produce ketones, and acidity will decrease the seizures. And then if ketogenic diet is strict too much for you, you can do other modified Atkins diet. So that is much less stringent diet, and low glycemic index diet. So those are options for treatment with the diet therapy if you do not want to do a strict ketogenic diet. And it's an important condition. So if you do ketogenic diet for sport, for loss of weight or anything, there are cheating days that you can do, like get out of the ketosis, but not in epilepsy. If you are taking ketogenic diet for epilepsy, you cannot cheat. You cannot have a day off. You cannot have a lack of ketosis, because anytime you get out of ketosis, that can induce seizures. So it's very important to stick to the diet very religiously. All right. So this is the diet treatment. So what happens if we have seizures that are not controlled? What are the chances that the seizures will continue to happen? Usually the chances that is about 25% of people will continue to have seizures unless we do something for them, either diet therapy or surgical treatment. So definitely ask your neurologist if you have any treatment options for that. And if you have any questions, please write down and I will answer your questions right away. And for that, I have treatment options for epilepsy and seizures. We have multiple medications, and not every medication works for every type of seizure. So for that, I put in a video that has all the treatment options and the medications for epilepsy so that you understand all of them, so that you can bring those treatments to your neurologist and see which one works better for you. And to see that, I have in this video. And stay healthy, and see you in the next one.